We're waiting 2-3 more minutes just to see if Tim Evans can make it on time. Otherwise, we'll shift the program around a little bit. So you can chat just a little bit more, and we'll get back to you in a second. Also, I have to announce to you that Laurie Garrett is not able to join us. You know, she's a senior fellow at the Council on Foreign Relations, but she also works as a journalist. And she's so nervous about all this election going on. She's afraid as a journalist she might miss something. So she's asked to be excused and do her journalistic work. All right, let's just get going. There's a fantastic panel up here already, and we have a lot to say, and obviously also want to have you be able to ask questions and give comments. Let me welcome you. My name is Ilona Kickbusch. I'm the director of the Global Health Center here at the Graduate Institute for International and Development Studies. You will have seen that this week we're putting on a Global Health Week. And there's a lot of events going on here. Those of you that follow Twitter will have seen some commentary that there seems to be an overload of health security side meetings. Not here, I say. We are looking at a whole number of other very critical issues related to governance in general. Today, particularly on financing, but also transparency and innovation, access to medicines, health in all policies, health R&D, and non-communicable diseases. So really trying to cover a breadth also of other issues on the global health agenda. And if you're interested in the other events, there's a brochure about that. We thought we'd head off with the notion of innovative financing and transforming governance, because there is a danger frequently to discuss financing without governance and governance without financing. And we hope we can bring it together a little bit here on this panel. You'll see from the organizations that are represented here that two of them are very much involved right now in moving towards a new way of financing, particularly with new country responsibilities. And this, of course, is fully in the spirit of the Sustainable Development Goals, but enormous challenges, because it's not just one organization doing that, it's 2, 3, 4 organizations that are doing that at the same time. And therefore, again, it means both more dialogue between those organizations and more dialogue at country level. That's why we've also invited 2 country representatives. I hate the classifications, but somehow we can't get quite around them. One country that gives money and works in partnership with countries, what we usually call a donor country, Germany, and a country that is frequently in development cooperation. Then we have Sri Lanka here, and particularly we're pleased to have a representative from planning, because particularly the integrated planning at country level is absolutely critical as we go through these changes. We were hoping to have Laurie Garrett here, as I already mentioned, because there is great movement in relation to financing. Those of you that have followed the news and also Laurie's blogs will know that there's a great concern about how much the United States will still be willing to contribute to global health financially, and in which areas that will be. Maybe that will come into our discussions now indirectly. But irrespective of that, I think, and I hope our speakers here will comment on that, there is a feeling that the way we finance global health over the last 10, 15 years, which is often also called, the global, the golden age of global health, that this is changing, that we need to revisit development finance for health, that we have to see how we finance the global public goods and how we match the international financing with the country-based financing. And obviously, as far as international financing goes, not all countries have reached the 0.1 contribution for a global health development on the one hand. On the other hand, many countries are still very far removed from the 5% GDP figure for global health. As I said, we had also wanted to start our discussions with a colleague from the World Bank, Tim Evans, to have the sort of overview from their perspective. But since we're still waiting for him, I think we should start with the two organizations we've invited. On the one hand, Gavi, and on the other hand, the Global Fund to Fight AIDS, Tuberculosis, and Malaria, and hear from them how this interface of financing and governance works, what they are aiming to achieve right now in terms of new models of financing with the countries they work with, but also looking into the future, as many of the global programs over the next couple of years will be looking to replenish their funding. And again, all this is happening at the same time with a replenishment goal in 2018. And therefore, thinking about financing leading up to that will also be very critical. And one of the questions that I'd also then like to hand back to our colleagues here from the countries is how countries are going to make decisions. If all these organizations come to them with their replenishment wishes at the very same time. And of course, as we discuss this, there is a financing dialogue at the WHO. There is the discussion around assessed contributions to the World Health Organization. And again, there are new organizations like in research, like CEPI, et cetera, et cetera. So there is a big call for more money. And therefore, we need to think how we do that and how we don't do that in competition, but in the spirit of the SDGs for the best of the countries. Maybe, Harley, if I could start with you, and if you could just give us a view from the Global Fund, where you are right now with the transitioning process, what you hope to achieve, and how you see this replenishment process coming up.
Thanks so much, Ilona. Hi, I'm Harley Feldbaum, Policy and Strategy at the Global Fund. Thanks for having us. It's great to be with these other guests. I'll start off with just a few big picture points because I think I totally agree with you. The golden age of those increases in donor financing throughout the 2000s was extraordinary, and by all evidence is over. However, the agreement to fund effective global health interventions that work has proven surprisingly durable. And so if 5 years ago we were having this conversation, Global Fund was in crisis, post-economic crisis, we would have all said the donor financing landscape is really fragile. And yet the Global Fund, Gavi, the World Bank, and others have all had successful replenishments over that time period. So there has been a somewhat durable agreement that financing these effective programs work. And so there's some inertia in the system towards that, which I think is helpful, but should not be taken for granted. There have not been huge shifts in development finance over the last 5 years. It's still dwarfed by personal remittances, so the money people send home from working abroad, and foreign direct investment. So it's still a small portion of the financing going to countries. The pledges to donor organizations has shifted some, but not an extraordinary amount. So for the Global Fund, 78% of Global Fund financing is from G7 countries. It has increased on the part of non-G7 countries and private sector donations, about 11% in the last period. But that's not a radical shift in where donor financing is coming from. And then just some perspective on what this means in the Global Fund context. The Global Fund allocated a little bit over $10 billion in the last period, $9.4 billion of which was to low-income countries or lower middle-income countries with high disease burdens. So not countries where transition is really an issue at all. So 9.4 out of 10.2. About 800 million was for upper middle-income countries and lower middle-income countries with lower burdens of disease. So this is a small subsection of at least the Global Fund portfolio that is getting close to transition and is having financing on a downward trajectory. And then the only countries that are in final and eligible grants, there are just 12 components, not even countries, but components, so AIDS, TB, or malaria in the case of the Global Fund, amounting to about $35 million out of the $10.2 billion. So just important to keep the transition from the countryside in perspective in terms of the total amount of financing going out from the bank, from Gavi, and the Global Fund. And then finally, just on the big picture side, one of the most incredible shifts in the last 15 years has not been in donor financing, it's been in domestic financing. So whereas at the start of this epidemic, the donor financing from PEPFAR, from the Global Fund, from Gavi and other donors, well, not from Gavi in terms of HIV, but was really almost all the financing available. Now UNAIDS estimates over 50% of financing for HIV is from the countries themselves, which is an absolutely spectacular transition from where we were 15 years ago. It's happened as well for TB. Most of the money going to TB is from the domestic resources themselves, some 83%, although that is concentrated in a number of upper middle income countries with high burdens of disease. So it's not spread across the world where the highest TB burden. And it's increasingly true for malaria, even though about 80% of malaria financing comes from either the Global Fund or other donors, about 18% comes from domestic resources, and that is growing. So that's been a spectacular transition in health financing, and that, to me at least, is the future of health financing, is the domestic resources coming from countries themselves, successfully funding their own health systems. Just on the sustainability transition and co-financing network and what's going on at the Global Fund, I'll just talk briefly. We took a very close look at this in the last strategy period, where we recognized we hadn't always done the best job delivering on sustainability. We had been set up as an emergency response, which doesn't necessarily mean you're thinking after you leave, but we've started to do that in a good way. A couple of aspects of it. One, on sustainability, we focus significantly on high-burden countries that spend less than 8% of their domestic resources on health. In those places, at heart, we have a sustainability challenge because you've got a high-burden country that's not spending a lot on health. So we've put in place some measures with WHO, Joe's here, a couple others on health financing strategies about how to address health financing, not just AIDS, TB, and malaria, in these countries. We focused a lot on transition. And again, this is a very small subset of the Global Fund portfolio. But we saw that it's extremely challenging to actually end funding. And often, because of the Global Fund's eligibility criteria, and Santiago will talk a little bit about how that differs from Gavi's as well, we are often the last donor in these countries. And so it's particularly challenging when the last donor leaves. And we've noted a number of big challenges in terms of procurement and some IP regulations around AIDS, TB, and malaria drugs. Particular challenges around political will, primarily for TB and HIV. But generally, as countries grow domestically and have domestic resources, the first groups they fund are usually not the sex workers, the men who have sex with men, the drug users, the prisoners who have TB. These are not populations that are first out of the gate in terms of domestic funding, either in implementing countries or in my own country. And also challenges in terms of NGO contracting. The way services are delivered in a lot of countries is through NGOs, but in many countries we're finding there are actually national laws barring government procurement through NGOs. which provides a huge barrier to delivering services for key and vulnerable populations. So a lot of focus on planning for transition. This takes a long time. All of the lessons from the Gates transition in Avahan, to the USAID family planning transitions in Latin America, to Gavi's transition lessons learned point to this taking a significant amount of time, on the order of about 10 years. The Global Fund is a challenge here. We have 3-year allocation models. We can only give 3-year grants. So one of the things we're pursuing, and one of the interesting governance questions, is our increasing partnerships with Gavi, with the World Bank, as we explore innovative financing mechanisms, like buying down a loan from the World Bank or from the GFF or from one of the regional development banks that then uses some Global Fund financing to reduce the cost of a loan for a country that then can extend well beyond the 3-year period of the Global Fund grant. But how that's governed, how we cooperate, which we're pushing on heavily, is a key issue. And then on co-financing, key area where Global Fund and Gavi both working heavily, but again, if domestic finances are the future of health financing, we need to be engaged in that heavily. And so 15% of every Global Fund grant is conditional, at least 15%, is conditional on increases in domestic resources. There's some exceptions for that. We don't apply that in CAR, we don't apply that in South Sudan, but for other countries, that's a key aspect of developing the sustainability of these programs. A few final thoughts. When we think about sustainability and financing, we often focus on the financial aspects of it. But if you don't have an epidemiologic lens on this, we're going to miss the boat here. The ultimate sustainability, at least in terms of the fight against AIDS, TB, and malaria, is epidemiologic success. It's reducing incidence rates down below the level at which the diseases continue to spread. We could talk about the key things we're trying to do in terms of progressive uptake of commodities, in terms of focus on key populations, the other things we're putting in place, but we really have to keep our eyes on the epidemiologic curves for AIDS, TB, and malaria, and for other diseases we work on, and how we're progressing against them. And then to Alona's 2019 reference, all of our organizations, World Bank, Gavi, and Global Fund are having replenishments in 2019. I think that will absolutely beg the question of how are these organizations working together. We've done increasingly more of it, the collaboration with Gavi on RTSS, the malaria vaccine, with UNITAID also here, and of course WHO has really been a good example of how we do that, and we're continuing to pull together, particularly on the health financing side of things, expertise from the World Bank, expertise from Gavi, and the Global Fund. We're all looking at health financing. We're all trying to figure out how to leverage those domestic resources. It makes no sense if domestic resources are moved for HIV if they come from vaccinations, or if our programs on vaccines or AIDS, TB, and malaria aren't supporting the broader health systems investments. So there's going to be a lot of collaboration needed, but I think, and what I've seen so far in a couple of key examples in Geneva, collaboration between these agencies is actually pretty extensive, but we're going to have to increase that going forward given that 2019 challenge. So maybe with that, I'll turn it back to you, Alona. Yeah. Thanks.
Thanks very much, Harvey. And of course, you'll be moving into a common abode soon, so that will probably also help. I just want to say, I'm not saying much about the people who are here on the panel because you have their biographies in this little leaflet, and we can save some time, and you can see how distinguished they all are and all the things they have done throughout their lifetime, even though the average age on this panel is a little bit lower than it normally is, which is great. So we'll move to Gavi and to Santiago Cornejo, and he is the Director of Immunization Financing and Sustainability in Country Programs. And if you, Santiago, could just pick up also on some of the things that, don't worry, it'll work. I hope so. Pick up on some of the issues Harvey has mentioned and share with us some of your experiences. One of the things when I was sitting in some of these transition groups, of course, also was that your focus in the government is changing. That whereas in earlier days one would have been sitting down with the Minister of Health, increasingly it's the Minister of Finance and even higher than that. And that's a key governance issue as well. So please go ahead, Santiago.
No, thank you. And we're not only moving to the same building, but actually we're very much aligned. And many of the points that I had, Harley mentioned. So I'm going to focus a little bit more on our experience around transition and what have we learned so far. But just to reiterate, I think what Harley mentioned, which is very important, Gavi had record replenishment even in this era of less donor, supposedly less donor financing, which shows that at the end of the day, value for money and results will bring the funding, in my point of view. So in the case of Gavi, I think it's a little bit different because of our model. Financial sustainability has been a core principle from the beginning from our Gavi support. And therefore, we have been going through a journey of lessons learned and adaptation of our model on how do we approach this issue of sustainability and transition. And perhaps one of the, from a governance point of view, at least within Gavi, not only the nature of the partnership, but also a board that is willing to learn, adjust, and not afraid to change and course correct is very important, because this is our aspirational goals. We want to bring innovation, so by default, we have a learning agenda. Immunization is very small relative to all the other needs, but even within the Gavi, what we were trying to do in immunization, if we think about it, we go back to the early 2000s when Gavi was introduced, countries were not even financing, the Gavi eligible countries, their very basic vaccines that they were 15 cents, 10 cents per dose. We were planning to introduce vaccines that would cost at the time $4 per dose, and we were planning to do it and the countries to be fully sustainable in the short term. So it were very aspirational goals, perhaps too ambitious, and maybe our model at the beginning was very simplistic. We thought after 5 years, these countries will be able to fully sustain these vaccines and then move on to the next generation of vaccines. That was not the case, so we needed to adjust. And we have some lessons that we learned in this period, and we continue to learn, and this is perhaps one of the key messages. This is we are continuing to adjust and to learn how we are approaching this issue of sustainability and transition. The first one you mentioned, is about country ownership. I know it's mentioned quite a lot, and we always talk about country ownership, but this is critical when we talk about sustainability. In the case of immunization, what we have is most immunization services are delivered through government means, so our counterparts are the governments. And we don't have parallel grants to other entities. And this is understandable given that our expectation is that these governments will take over the financing of this program. So it's very important to start from the beginning with them. Of course, we changed or adjusted our counterparts. We started with immunization managers. That's not enough. We started with ministers of health. That's not enough. Now we also include ministers of finance. Our engagement now includes also parliamentarians. We are looking at all the different stakeholders that need to be engaged in this process when we talk about country ownership. The second element is about co-financing. And again, part of our lessons was in this model at the beginning, we thought that after 5 years, countries will start sustaining these vaccines, but it was a voluntary co-financing model, and it did not work. Countries did not start co-financing on a voluntary basis, so we introduced this mandatory co-financing. And in this co-financing, all countries are required to pay, even a small amount, and we feel that this is very important from an ownership point of view, linked to the first point. Is all countries, irrespective, so we differentiate their co-financing based on the ability to pay, but all countries need to start co-financing, and slowly, there's a gradual increment on their co-financing. And the idea is to smooth this transition or financial transition and to avoid this budgetary cliff that all of a sudden donor financing is pulled away, as we have seen in the past. So that's very important from a policy design, but from an institutional point of view, this co-financing policy has been institutionalized in all of our processes, in our communication, and we monitor and we track it. Actually, the continuation of our support is subject to countries committing and honoring their requirements and commitments. And we do this in an annual basis. Very interesting what we have seen since this started in 2008, this mandatory. We have never had to suspend the program because the countries did not honor their co-financing. So one of the lessons is if the rules are clear, countries will honor to their commitments, and we have seen. Very important is the issue of predictability, and here's where our eligibility policy is important. In my discussions with transitioning countries, Gavi and non-Gavi, one of the things that they value the most is predictability. When we talk about transition, we need to think about the planning and preparedness. And this is one of the key elements. Harvey mentioned 10 years. We have our last phase is 5 years where we really plan. But it's at the end of the day, it's starting from the beginning. How do we start that dialogue, that planning for and prepare? Of course, it's not just on the government side or our engagement with the government. I think public-private partnership, what we bring is the issue of pricing. We can talk, it's one side of the coin is the the increment from the government side, but the other one is how do we make these commodities affordable? And this is one of the critical elements. Again, we started very simple, thinking that 5 years was long enough. We realized we need a longer term in terms of creating that environment, that market shaping. And also now we delinked a little bit our financial support with the access to these prices, because we realized that even after our financial support ends, this need for countries to understand what are going to be the financial requirements post our support is very important, and that's why we have created this policy about access to prices post Gavi support. When we look at all these policies together, we are seeing that it's working well. There are challenges, particularly in fragile contexts where maybe this is where we're seeing some of the countries, some of the concerns, but we're seeing how countries are increasing their share. They are paying more on time, and more important, 15% of the programs that we have introduced, they are now fully self-financed by countries. What are some of the challenges? And this is perhaps when we focus a lot on the financing, but we cannot underestimate the institutional capacity of the programmatic sustainability. And perhaps that's one of the areas where we have the greatest challenges and we haven't worked so far. We need to look at the issue of management, issues of the broader system, governance, procurement, financial management. Those are some of the areas that will have huge implications in this transition, and where we, as a global community, we need to do better, we need to improve. Because linking to your comment about the next replenishment, I think it will be about results. It will be about, and what, of course, donors are looking at is part of this around transition.
Thank you very much. So we've heard from the Global Fund and Gavi. We've also heard how they are starting, or no, I shouldn't say starting, how over the last years they have worked together much more, are trying to adapt their financing models, are cooperating also at country level, and both of them also supporting health systems. And I'm sure in some of your questions you're going to come back to that. I'd like to welcome Tim Evans from the World Bank, who has joined us now, and I'd like to give you the floor straight away, Tim, to say how this a change in the health financing landscape is being perceived by the World Bank. I remember being in a meeting recently where the head of the World Bank, Jim Kim, spoke much more broadly about health financing, saying how corruption and tax evasion was part of the discussion and the thinking about health financing if people didn't have the money in the country to actually support their health systems and their programs. So that's actually one of the reasons, that conversation with him, why we set this meeting here today, linking governance issues of a broader nature with financing issues. So Tim, I'm handing you the microphone because we only have two. Here you are.
Thank you very much, Lona, and apologies for being late. I was actually in another meeting on financing, but financing of preparedness, which perhaps I'll come back to, or maybe we can take on in the questions. I think the bigger context is the one of financing for development, and where this intimate link with governance is so fundamental, and it's governance at multiple levels. Let me begin by saying that the big sort of awakening, I think, in the global development community is that, and this was very clear in Addis and articulated by our chief financial officer in sort of the billions to trillions strategy, and it is that there isn't anything that development finance on its own can solve. Okay, in health, we put $36 billion a year into health development, which is a good number, but that's out of a total of nearly $9 trillion that are spent globally in health. And when you boil it down to low-income countries, it's still development assistance is a minority share of the financing. And I think this realization that domestic resources are the focus of interest is the awakening. And I think, therefore, we need to be thinking and much more explicitly about how it is that development assistance is supporting the mobilization of domestic resources. And this is in large part why in 2014 we created something called the Global Financing Facility for Every Woman, Every Child, because we felt very strongly that we need to think about ways in which we could let countries lead in the development of their health systems towards universal health coverage with a clear focus on results that are universally bought into, which are the rights and entitlements of health for all women and all children and adolescents, but also with a very explicit financing strategy. And we simplified it in 3 ways, which was one, that first you've got to have better use of the resources that are there. And we call that smarter, right? And as there are efficiencies, you allocate better, you implement better, and you plug the leaks, right? Financial management is enormously important. It's not specific to the health sector, but understanding what the opportunities are for strengthening public financial management are absolutely critical to avoid or diminish the problem, Ilona, that you were referring to. So, and we very deliberately started with the smarter part of it, because with ministers of finance, if you can't make a good argument that you're using existing resources well, then there's no further discussion. And the further discussion that we want to engage is we want more resources for the sector. Because even if you use, all resources more effectively, you're still only, in many settings, only going to have 25, 30, 40% of what you need. So how do you move from 40% of what you need to 100% of what you need? And that's the second part of the strategy, which is scaled financing. And so really looking at full systems needs to make sure that you're going to achieve full financing. And that doesn't happen overnight, but there needs to be some plan to get there, and it has to be fundamentally a function of domestic resources. Now, this includes public sector, but also the private sector, and this has been a huge blind spot in so many financing discussions. And the biggest untapped pool, and it's not a pool, but the untapped area of private financing is the pay-as-you-go systems that characterize way too many low and middle income countries today. Those are out-of-pocket payments when people fall ill. We're all in agreement in terms of the evidence on that. It's the most inefficient and most inequitable way of financing. Where we're lacking good approaches to address it is, how do you crowd in that out-of-pocket payment? How do you get it into pools that can be managed so that you can allocate more effectively and grow the financing of your sector in settings where taxation systems are weak and not improving very quickly, and in settings where formal employment is also not growing very quickly. So you have a massive middle informal sector which doesn't lend itself to the Beveridge and the Bismarckian systems of financing that we've grown up with in many OECD countries. So we really need to think very credibly about both the public and the private in scaling. Finally, sustainability, which is absolutely fundamental, but it really challenges then that the role of ODA, which is to catalyze and contribute to the overall financing and not substitute. And too often in the past, we've seen development assistance in health substitute for domestic resources. And this is not the sort of thing that we want to do. So how do we build on the Gavi co-financing? How do we make it stronger? How do we help governments, for example, structure subnational financing agreements so that with massive devolution of the form that is very popular for reasons not entirely limited or relevant to health, but which are political imperatives, as in Pakistan with Amendment 18 of the Constitution in 2010, where they devolved the federal responsibility of health to the provinces. How do you manage effective subnational financing in those contexts? And how can development assistance play a role in strengthening that? And we have a wonderful example in immunization in the context of Pakistan, where we've created not only a federal provincial transfer of responsibility for financing of immunization, but a retransfer from the provinces to the federal to ensure a pooled procurement of financing of immunization for the nation. And therefore, the provinces are getting much lower prices, but they are held to account for the financing of that in a way which has them owning and controlling the system. It's a wonderful example. But those are the sorts of sustainable mechanisms that take us well beyond, I think, the initial era of billion-dollar funds being thought to be a solution, which they were a very important change in the architecture from where we were prior to the billion-dollar funds. But it gives an indication of those monies really are leverage monies, catalyst monies to strengthen national systems. So the governance challenge, in my mind, is how we in development assistance can be much, much more effective and accountable in terms of strengthening domestic financing across those axes of being smarter, scaled, and sustainable. Stop it.
Thank you very much, Tim. And I think from your words around the country financing, I think it would be good to move straight away to Susie Pereira first, who is in the planning and management unit of the Ministry of Health in Sri Lanka, and how all these things that are discussed here, it'll work automatically. We always want to push buttons, don't we? So how does that sound to you? How did it work for you? What are your expectations from these organizations in terms of financing and governance?
I think I'll first explain the kind of financing system we have. We have a general tax-based financing system, and the governments have been committed to provide free health care at the point of delivery. But if you look at the overall the health expenditures, we see that the out-of-pocket expenditure has come to around 42% of the total health expenditure. So in that context, but if you look at public health and immunization programs and all the control programs, really though the topic is on innovative financing, the Sri Lankan model is that the governments have been committed to that aspect of care, the public health side of it. So even immunization, the governments were already committed, and as far back as year 2000, I think there is a ADB report, an external evaluation, which was done at that time, already said that the financing, the government component was for immunization around 75 to 80% of the total need at that time. So the gap is what was actually put in by the external agencies. Now, if you take in the total health expenditure, it's around less than 5% that the external donor support comes in. But what came in was critical. But if you take immunization, we are now totally 100% financed by the government, except for a small component, which still, I think it comes through the UNICEF, but still it's Gavi supported through the UNICEF. But the government is totally committed to funding the immunization program. Immunization, HIV is supported by the Global Fund, but TB and malaria we've eliminated. And so actually it is the government's commitment has been there. Now, how we've done it is even to make it affordable. One thing is that we've been very precise in estimating the requirements and identifying precisely how much we need, looking at the future forecasts of the budget, the cost of these vaccines, and that has been a very clear methodology has been followed. And if you look at the procurements, it has been a competitive bidding procedure. Sometimes, I think, as you mentioned, the cost of these, which came through probably UNICEF, would have been higher, but we've been able to go for lesser amounts because we followed a competitive bidding procedure. So we followed all these, and that's how I think it has been made affordable. Now, in our system, we are a small country. By the way, we are an island nation, but 20 million population. Health system is decentralized, but obviously, like the states are very small. So still, for all our drug procurements, it's a central system we follow. So in that way, it becomes a little efficient. But if you look at the total financing, if you take in terms of GDP contribution over the years, there's not been much of a change because it's like 1.4, 5, 6, 1, around that. It's been steady. So that's why actually we find it difficult to fund the non-communicable disease component. The newer areas are becoming difficult to fund. But we've not compromised on any of the maternal and child health, immunization, the communicable disease. That has been the success and what we see. So at the moment, what we're trying to do is, we feel that the capital investment on some infrastructure projects that we need to look at curtailing some of that. And we've improved essential drug lists. The pricing of drugs have come down. So we are trying to make it more efficient in terms of how we deliver the health services. And also reorganization of health services is on the cards, especially on primary health care. And that has been our success, but we think that we could do much better in terms of addressing non-communicable disease. So there is a lot that we can talk of, and also performance, performance management is another area. We've been very successful for the public health related, but not so much in terms of the hospital curative side. And that is an area that the government is keen to sort of improve on.
Thank you. And you've mentioned, of course, two areas that always sort of lose out in many of the programs, the whole area of health promotion, prevention, etc. And linked to that, of course, very much the whole issue of NCDs. And with 2018 coming up and the discussion on NCDs in the UN General Assembly, that, of course, will be raised again. How do we support countries in addressing the NCD areas? A lot of that will, of course, also be regulatory work at country level, etc. But again, support in governance will be needed in that. So last but not least, we have with us Henrik Schmitz-Grünotte from the German representation here in Geneva. I was able to be at a meeting last week where for the very first time Germany hosted a health ministers meeting in the context of the G20. The German Chancellor opened it. She looked very sternly at the countries around the table and she said, "There is no free lunch." and drew attention to the big gaps in health financing, mainly related to global public goods that we need to take forward. One example being the WHO Contingency Fund, which will be broke in August unless something happens, and we might get back, to some of those issues. But over to you first, Henrik.
Thank you very much, Ilona. And maybe also starting by the bigger picture. Tim mentioned the focus on development finance overall. And of course, we have the 2030 Agenda for Sustainable Development, which is a very broad agenda. Even if you look at SDG 3, the health goal, it's a lot broader than all the goals we had under the MDGs on health issues. So it's really, it needs a different approach, and of course the World Bank coined this term from billions to trillions, and that's in a way the challenge we're facing. It's also, I think, a second important notion of the 2030 agenda is this indivisible nature, that the recognition that you cannot achieve a single SDG on its own in isolation from the other SDGs. Speaking last, of course, always brings the risk that most of the points you wanted to make have been made already. I think one point which I want to stress here, and which is one of these new approaches which are required, and Santiago alluded to this, is this necessity to move towards multi-sectoral approaches, whole-of-government approaches. It's not sufficient to speak only with the Minister of Health. You need the Minister of Finance, you might need the Minister of Education somehow involved, and you need national strategies for health and for health financing. Second point also has been made already, but this is this need to come to more holistic approaches to financing. We heard about the de facto importance of out-of-pocket payments. It's, I think, and we need to recognize that de facto, I mean, over the past years, and even in low-income countries, the biggest resources going into health are actually domestic resources. And probably a more humbler approach from the international actors is also needed, by seeing the limitations of their funding, and really working on how to leverage these domestic resources and make sure that they flow through pooled mechanisms, are used more efficient and more equitable. With the 2030 Agenda for Sustainable Development, we also had the Addis Ababa Action Agenda adopted on financing for development, which explicitly recognizes all these different sources of finance, public and private, domestic and international. For German development cooperation, I mean, there's a lot of sort of fears that overall development cooperation funding will go down. Germany achieved for the first time last year the 0.7 target, and we're committed to stay there. So I think there are also positive news coming out, and it's important to keep demanding countries to invest in this sector. About 850 million we're going into the health sector. But I think it's here also important that we focus beyond just the health sector and the health financing. Just looking at this finance sector and how we work on supporting the leveraging of the domestic resources. I think one initiative which came out of the Addis Ababa Summit was the Addis Tax Initiative, where donor countries sort of enter into a partnership with developing countries to support their tax systems, to become better, to leverage more resources. But there's the wider concept also, and it's also something German Development Corporation has been engaged on. This is the good financial governance concept, from resource mobilization to budget planning to financial controls to public procurement, to to use these efficiencies. Then there's another sector, also not very innovative. During Germany's G8 presidency in 2007, we launched the Providing for Health network, which helps countries to develop health financing strategies. It was initiated jointly with France, and many countries have joined, and WHO and World Bank are the co-hosts also of this network. And then there's the last element of intervention is German support to set up health insurance scheme in countries. Tanzania is an example where there's good progress, and we're currently engaged in 8 countries in this sector. So I think these are important elements to keep in mind. And it's not the health governance mechanisms which are the decisive ones here. For our bilateral cooperation, the decisive governance forum, in a way, are the government-to-government negotiations, which take place every 1 to 3 years, depending on country situation, where the priority sectors are agreed and priority interventions are agreed. And then we have the full spectrum from technical cooperation to financial cooperation, from grants to loans in country which have middle-income country status or are emerging economies. So there's a whole set of these issues. But we, of course, also invest into the global mechanisms. And I think here the points have been made, and Harvey alluded to this need. When the Global Fund was created, it was created mainly out of a humanitarian mindset. We needed to save lives. People were dying. Medicines were in theory available, but not reaching those people. And in order to move fast, there was an approach to set up sometimes parallel systems just to get the medicines out. But I think now with this focus on sustainability and the recognition that the support will be limited, I think in a way, it dawned on everyone that we need to find a different way of working. And that's exactly through working through the national systems and strengthening these systems and not replacing them. And I think we have seen in the different fora from Global Fund and Gavi board important moves there to change the direction slightly, a wider understanding of what this means and how processes need to be adopted. Focusing on maybe on the national level, where both this bilateral cooperation and the multilateral cooperation comes together, and where in the end they need to support whatever the government wants to achieve. I think it's essential that this national level and the national strategies really become the guiding light again of all interventions. This is there to an extent, but I think it's the time to reinforce that, and that we in a way also start on working of overcoming fragmented processes, which stem from the fact that every organization investing tends to have its own application formats and its own coordination formats, and basically, I mean, sets up its own governance system on a country level. And I think this is also the moment to take a look how we can overcome this fragmentation. And then, of course, the issue, which is also recognized in the 2030 agenda and in this understanding that we need a lot more finance than public finance can be, that we find better ways of working with civil society and private sectors. On the global level, I think we also face this issue of a need to overcome fragmentation. And Ilona, you mentioned the different replenishments coming up. There's always a danger, I mean, either of creating a replenishment fatigue, but also of overburdening budgetary systems of donor countries. I mean, we can make pledges to a certain amount in a certain year, but you can't sort of for different organizations make the same pledges. So really a need to come to a more coordinated approach. And I think a final point I want to make is also a more coordinated approach on what we understand under health system strengthening for universal health coverage. And I think we have some very exciting news there with the establishment of UHC 2030 as a partnership replacing IHP Plus, basically bringing together all the different networks and stakeholders to create this coordination forum on a global level. And we also, and invitation to all of you for tomorrow, we have now a joint vision paper, Healthy Systems for UHC, Joint Visions for Healthy Lives, which will be incorporated into UHC 2030, will be launched tomorrow at a side event at the Palais des Nations, and which should help to align the approaches of the different actors on health system strengthening.
Thank you very much. So we've had a fascinating tour de force, I should say, around the issues of financing and governance. I would have loads of questions to put to the panel, but I think in good democratic fashion, we should open it up to you, that we hear from you what issues you want to hear more of, or things that you would like to comment on in relation to what they've said. And I was expecting that Rob Yates would raise his hand first. So please give him the microphone. I have never understood why our institute doesn't give us more microphones, but please live with it. Rob, please go ahead, introduce yourself.
Thank you, Ilona, and I'm glad I didn't disappoint you with putting my hand up first. I'm Robert Yates from Chatham House in London. A lot of you, virtually all of you, mentioned the importance of domestic financing as the future, and that's clearly the case. And in particular, what we're talking about is domestic compulsory financing, pooled financing. As Tim says, that might not necessarily be a Beveridge model or an NHS model, but moving to a system where the healthy, wealthy cross-subsidise the sick and the poor. Sri Lanka is a country that's made that transition very well, and you're getting very good results out of that. But often the problem seems to be political commitment, as you're saying, that a lot of countries just aren't introducing that type of health financing system. So recognising that political commitment is the number one constraint, what are your organisations doing to try and generate political commitment to an equitable and efficient health financing system in the countries where you're working?
Thank you. Joe here, I think, if you go to the middle there, and then we can distribute it from Joe onwards. It's difficult. Yeah, sorry about these logistics.
Sorry, I'm going to sit again. Joe Cutson, and from Ilona at the beginning, you talked about the problem of sometimes having financing without
from
governance.
WHO,
I was going to say.
Yeah, for the others.
And actually, whether it's financing without governance or governance without financing, I'm from the Department of Health Systems Governance and Financing, so I hope that helps. A lot of the discussion, as it often does here, not entirely, but it often focused a lot on the financing issues, which I also like to talk about. And certainly some of that is the case, and we heard in the last presentation from Henrik Schmitz that perhaps one of the most important things that can be done on the revenue side of things is not so much about health, it's about the agenda to strengthen domestic tax systems, for example. And in fact, one of the concerns I have is sometimes we focus too much on revenues on the health side, and there's not really a lot of scope for action there. Where there is, and maybe it's more you could frame it under governance, is how we address that side of the sustainability equation. And in particular, and I think it's maybe a particular challenge for, let's say, for Global Fund and Gavi, because by definition, by what your mandate is, you're looking at things very much program by program. That's the responsibility. But one of the core things that can be missed in that case is looking at the issue of having multiple duplicating systems, for example, for information, for procurement, and so on. And this is really at the core of something we've developed that I think should resonate, which is called a cross-programmatic efficiency analysis, and precisely to get at these kinds of issues, that the right unit of analysis, whether it's about the revenue side and being clear that not every disease gets its own tax, for example, but also from the efficiency side as well, that yes, improving things within programs matter, but fundamentally looking across the system is critical as well if you're going to really start to address some of the core issues. And certainly at the core of governance, I think, is having a sound, solid, and unified information system for the system, so you can actually, those governing the system can know what's going on. So I would see that might be one issue, and really trying to get a sense in terms of the prioritizing, let's say, what might be called a transitional investment strategy, of looking at those things that perhaps are less program specific and more kind of underlying cross-cutting systems, and ensuring that they're strong enough to serve multiple programmatic needs.
Thank you, Joe. And that gives us, of course, totally new dimensions of what we used to call health and all policies into, quite different understandings of governance. No, you've taken it away from her. She was going to be the next one. You see how strict we are. Go ahead.
Hi, Ali Jo Shipman from International Pharmaceutical Students Federation, one of the several student organizations here, so our question will be a little bit different. But just wanted to bring up that often students are excited about advancing public health initiatives, but become discouraged or shy away when these sorts of discussions come up. And part of this could be because there's often a lack of focus in our education about health finance and governance. So we don't necessarily have that background or that context to contribute. So we wanted to know what are some practical ways that we as student organizations can educate and engage our student and new graduate members in discussion and innovation regarding health financing, governance, sustainability, so that the future of healthcare is involved in these discussions, since it will be very, impactful on us as we start our careers.
Thank you. And there was one more over here. And yes, that was this lady. And then we'll do a first round from our panel, please.
Thank you so much. My name is Gurawan. I worked until recently for the Global Fund. I'm going to echo Mr. Yates' question. As part of my assignment, I was involved in a grant signing process with the famous 15% co-financing requirement. And while we were negotiating this grant, the Minister of Health was risking to be changed. So my impression after working there, and I think my former colleagues would agree, is that political instability was one of the key barriers to us ensuring the co-financing requirement was met. So my question is, what do you see is the role of such organizations as Gavi and the Global Fund in contributing to political stability, and not necessarily government stability? Parties and ministers will go and change all the time, but at the level of commitment and strategy over a longer period of time, so that we don't run into these risks over and over again while ministers are changing. Thank you.
Thank you. So if I can turn back to the panel and ask you to focus particularly on this political dimension, political will, political stability, influencing political decision-making in a variety of ways on the one hand, and on the other hand, that broader governance issue that was raised in particularly also by Joe, but also came from the panel in terms of how health governance relates to the broader financial governance. If I can ask you to start, Tim.
Thanks for great questions. Just in terms of politics, yeah, leadership is really critical. There was no randomized double-blind control trial that led to the Beveridge report and the commitment in the UK for a national health service, right? So you have to take risks and do the right thing, and ensuring a universal entitlement to health is the right thing. And so how do we advocate on that? couple examples. Our president said here at the World Health Assembly 4 years ago, or almost 5 years ago, 4 years ago, the World Bank is not promoting user fees as a way of financing the system. And that's a very important policy statement because of the past, in which there was an era in the 80s and 90s where there was a proposal that is a way of financing systems. So clear break from the past. Second, some neglected issues. Our president has said that no country will be competitive if over 30% of their children are stunted in the 21st century economy. And so he's mobilized a huge amount of highest level political support for addressing the unaddressed issue of childhood stunting, which has massive impacts on cognitive development, educational attainment, employment, and growth of the economy. So it's instrumental with respect to how well society is going to do, but it's also focused in such a way that it's not trying to change everything at the same time. So those are just two examples of the politics. In terms of political stability, I think it's a great question. I mean, the life expectancy of ministers of health is amongst the lowest amongst ministers. It's usually less than a year. And I think there's only one other type of minister that has a lower life expectancy, and it's ministers of finance. So you have to anticipate turnover and transition. And I think in the area of financing and governance financing, a good place to look at how to build greater stability is look at what the capacity is in a Ministry of Health to manage its own finances. And when you do, it's pretty humbling. Often there's little or no capacity. There may be a single health economist who suffers from loneliness, and there's no discourse and dialogue with Ministry of Finance. And Julio Frank, who many of you know, who was Minister of Health in Mexico, he made a deliberate attempt, which I think is exemplary, but something that we need to scale across many countries, to actually build a joint unit on financing between the Ministry of Finance and the Ministry of Health. And the reforms that he led had the full backing of the Ministry of Finance because he developed that dialogue and capacity within the ministry to have that discussion. So the minister can change, but that there's some continuity in terms of good technical capacity within. Let me just finish quickly on Joe's comments, questions. Absolutely right. Uwe Reinhardt is famous for saying syntaxes are great, but there aren't enough sinners. But syntaxes are great. And the FCTC, which is a masterpiece of global governance, the Framework Convention for Tobacco Control, we still don't have adherence in terms of the rates of tobacco taxation. And we hosted a meeting on tobacco taxation just about a month ago at the bank. We had 70 persons from ministries of finance attend from 70 different countries and talking about how to implement. And the joint learning on implementation of tobacco taxation was absolutely fascinating because there's no one size fits all and there are all sorts of issues. But what was great was to see that there was no argument about whether, and this used to be a massive debate in public finance about whether or not hypothecated or singular taxes on specific issues were good things. No debate whatsoever, but they're not sufficient. So another good example, eliminate useless subsidies in agriculture, okay, as an example, or fuel, right? So those are things that, will lift all boats. But I just want to finish by giving one example on what we did in the context of the Ebola crisis in one of the affected countries, whereas we moved from a system of payment of health workers, which was by brown paper bags and cash direct, in a setting where the number of health workers was going up exponentially because health workers were getting an extra bonus for working in the emergency setting. And we went to an electronic digital system where people who only had bank accounts would get paid. And about half of the workers that were on the rolls to get paid disappeared overnight in the electronic system. And so this system now, which was introduced in an emergency, has actually been continued because it's helped manage a chronic problem that a lot of public bureaucracies have, which is called ghost workers. These are people that are on their roles but actually aren't working in the system. They're either retired, they're migrated, or they're dead, or they're fictional. And so there are massive efficiencies that can be made on using technology, mobile banking, and other systems that bring a level of efficiency and transparency to the system in sort of discrete settings.
Thank you. Susie, can you share with us a little bit how you cooperate, perhaps with the Ministry of Finance, along the lines maybe of what Joe has said, or have you found other mechanisms? And how's the turnover, the life expectancy of your ministers, health and finance? Maybe you can share a bit of that country perspective with us.
Well, you're raising 2 points. I'll take the second one first. Well, ministers, health ministers can come and go, but generally the health policy is set at a much higher level. So it doesn't really depend on the minister per se, but that commitment comes at a much higher level. And it also is all about the development of the country, the people, the literacy rates, and what really people want. And so it's at a much higher level. So whether a minister has an idea about this, no, if the national government, because we do see national government in the budget speeches, certain things being reflected on what the highest level wants. So it comes with the understanding of the other development perspectives of the country. So that's the difference. But recently, we see more ties between the finance ministry and so much so that there is a review which happens, which I think is all part of the good governance program that the current government has initiated. Not that I'm trying to promote it, but I'm telling you that there is a good, something good that is happening, and we are also becoming to understand how we need to manage the finances better, because I totally agree with Tim on our capacities, whether we are actually finance planners and managers and really doing that part, or where we just spend what is given. So there's a difference between that, and now we have come to understand that. I think that's another thing that the government, this is coming from the top, you know, the top thinking coming down to the Ministry of Health, and not only Ministry of Health, but other ministries also, how to improve, you know, the way that we are utilizing and the funds. But I think it's also because of the problems that, the limitations that we have, and with the limited resources, how do we manage better? But that understanding is there now.
Thank you, Susie. And it goes back to Rob's point in another way. You know, what is the overall good governance message in the country that comes from the top of how the whole of government is approached, is responsible, is transparent and accountable. I wonder, Santiago, when you're in the countries, do you argue for a sin tax?
It's quite interesting. Actually, when we started this work on financial sustainability, we did. We were really pushing for parallel trust funds, just looking at immunization, just a trust fund, a tax. But we're realizing more and more that what we were talking about before, that at the end of the day, what we need to talk about is about the sustainability of the health sector, not individual programs. And this is why now we're working much closer together with the Global Fund and the World Bank on these financial health financing strategies. Even though Gavi is the first one of all these transition agencies, our contribution is really small. It's 1%, 2% of the health budget. But we realize that if we don't talk together and we look at the sustainability of the health sector, we will never achieve the targets that we have. So we changed our views. We started with a very parallel, looking at our own taxes, trust funds, and now we're moving more towards a broader perspective.
Thanks. You want to complement that, Harvey?
Just real quick, I think on Mr. Yates' point and a few others, there's a bit of a setting the stage of the perspective we're coming from matters, and asking what these Geneva or DC-based organizations are doing to countries, I think is not the right approach, doesn't reflect how we do business. We are here to serve these countries. We are here to fund effective, impactful health programs alongside the countries. And what we can do is not govern their politics or change political accountability. We can set the right incentives. We can hold ourselves accountable for impact. We can streamline our processes and our mandates, so in cases where you have fragility or conflict, we can provide exceptions. But it's not our job to tell countries what to do. We're a few hundred people in Geneva. That's not the right setup. It's to serve the countries as best we can. And you will see variable progress depending on the governance in the countries, and our job is to encourage that as best we can. But I don't want to leave any impression that our job is to enforce that.
Thank you. From a donor country perspective, do you think these guys have changed?
I think they're in the process of changing. And no, but I think one example, this joint approaches to discussing health financing. I mean, in the past, yes, it often has been the case that every agency advocated for funding to its own programs. And of course, I mean, the board holds them accountable to whether they ensure that there's domestic financing and the contributions being paid. But I think we really need to move beyond these agency-specific approaches. And I think there's a good basis. Because I think if you have WHO, World Bank, Gavi, Global Fund, and the other donors in the health sector jointly approaching Ministry of Health, or often with the Ministry of Health, the Ministry of Finance, and presenting evidence why it's worth investing into the health sector. Either in economic terms or also in political terms, because you get re-elected. If the people are happy in your country and they get the health care they need. I think presenting this evidence is very powerful when it comes jointly, not when it's a piecemeal approach of looking at the different programs. I think the other element which is important also on the longer term stability is to work with a broad range of actors on the national level, or engaging in dialogue, be it civil society, parliaments were mentioned, and working on legal frameworks, getting bills adopted. Not so much, I mean, the Minister of Finance granting a certain funding, but really creating longer term commitments to the health sector.
Thank you. Second round of questions. I have 1, 2, 3 people here. The shorter your questions or comments, the better, the more people can ask or make a statement. So just start with someone over there. They're more or less, and please be brief and then just hand it back.
Yes, thank you. Tom Hurley, I'm with the Bill and Melinda Gates Foundation. And first of all, thank you all. It's really great to hear that each of your organizations and governments are really thinking through these issues. And certainly we as a foundation, we continue to support governments, work with fellow donors, and be thought partners to our financing agencies. But these are unique times, and I think we need to acknowledge that it is changing and transitions are coming. So I have a very, very simple question. What keeps each of you up at night? What do you worry about?
Okay, will you hand it to the gentleman behind you? Yep.
Hi, good afternoon. Patrick Nowak, formerly UNAIDS, now at Global Future, an NGO in Geneva. Thank you very much for the comments. And since Tim Evans mentioned agricultural subsidies, I wasn't going to go there, but now that the can has been opened, it feels a bit like we're tinkering on the edges. So we've got issues like agricultural subsidies, manufacturers producing unhealthy food and unhealthy beverages, all these sorts of things. Countries going to other countries to sell weapons for 110 billion, et cetera, et cetera. So there's a lot of activity that is towards economic growth, but is not exactly helpful to health. So how do we address that? Are we tinkering on the edges and trying to come up with smart ways of trying to fix who has broken a window without going to the people who have actually broken it in the first place? Thank you.
Okay. Yeah.
Hi, my name's Tabitha Hart. I'm from Stop AIDS in the UK. So I have two questions, but I promise to keep them very short.
Question, please. One question.
Okay, so my one question then is probably more for Gavi and Global Fund on what you see the opportunities are for collaborating in the future on market shaping, and what might be the ways for strategic decisions there, particularly so that we can access continued lower drug prices and free up funds to access new drugs.
All right, thank you. Can we move over here, please? To be a bit... So, the lady here, yes.
Thank you. My name is Zandile. I'm a student at Imperial College and a current intern at WHO. My question is, there's been so much focus and support given towards tax-based financing, whereas in some countries, there are significant proportions of citizens that are informally employed, where you'd find that because of that, there's a skew or a bias in terms of how the overall health system financing structure works. So I want to find out, what are your organizations doing in support of that part of the economy, and also how we can actually probably work towards improving the overall health system structure?
All right, I'm going to be preferential about ladies.
Great, thank you very much for a fascinating afternoon. I'm just interested, given what you've said about domestic financing, and just wondering from your perspective what you think the role of the local people in the countries are, the ones from whom the states are committing funding for entities. Do you see a role for them at all?
Can you introduce yourself?
I am Togo Elfik Puli from Uniting to Combat Entities.
Okay, thank you. And there were one or two back there, and then okay, 1, 2, 3. If you speak very quickly, then we'll fit you in. Thank you.
Hi there, Laura Kerr from Results UK. I was really interested to hear you mention so much about lessons learning from transition. So we know one of the most kind of imminent ones are from the Global Polio Eradication Initiative. How do the organisations kind of on the panel today see that they can kind of work together to make sure those lessons, especially around the technical capacity that's been kind of mentioned quite a lot today, to make sure that we don't kind of see kind of regression of certain kind of health services and on the health system in general?
Thank you.
Thanks, James Sale at Save the Children. We mentioned, what Tim and Joe mentioned earlier, actually, that how important domestic resource mobilisation is in revenue raising, and that this is actually a cross-sectoral issue. It's not a health sector specific issue in many ways. How can we make sure that we're engaging the right experts, say tax reform, customs, system experts that work outside the health sector with the health sector to make sure that there's enough revenue to run health systems effectively?
Thank you, and the last one back there.
Homir Zavi with CDF Foundation. This is a question for Tim. The World Bank classification has a huge impact in terms of what countries get. Where they get resources, funding, even pricing. When companies actually decide their pricing, they look at the World Bank region and decide. Unfortunately, that doesn't really map well with the healthcare needs of the citizens. Has World Bank ever considered coming up with a separate classification just for healthcare?
All right, thank you. We have just about 5 minutes for answers, but I think if you select one or two of the issues that were put forward, and then there's some opportunity afterwards, I hope to at least have a word or two with the members of our panel. Harley, would you start?
Sure, I think actually Tim's best place to talk about the development finance versus the health financing, so I'm going to skip on that because I think you're better informed than I am about it. Tom, what keeps me up is just the continued demonstration of results with the Global Fund model. We don't set up parallel data systems, we don't set up parallel procurement systems, we measure our results by the progress at the country level. And so what keeps me up is ability to deliver on a really aggressive strategy, including ending AIDS, TB, and malaria, plus supporting health systems, plus human rights and gender. And making progress on all those together in a short period of time is really, really tough. Just to the last question, I'm sure Tim will get on this as well, but there's a lot of debate about the use of GNI per capita. It is a regularly updated number, so that's the reason a lot of organizations use it. We do look at health needs. There are a lot of things it doesn't get at in terms of inequalities in countries, subnational divisions, but as a proxy, there's not a lot of other spectacular measures in terms of economic growth.
Thank you. I wonder if Harley ever sleeps then, if that's what keeps you awake at night. Santiago.
I will answer the same question. What keeps me is on the programmatic sustainability. I think we have worked quite well, quite a lot on the financing side, financial instruments, working together with our partners, but on planning. But what we are realizing is that the issue about institutional capacities, institutional development, and this is where the leadership is important. It's not about the minister, it's about the kind of decision makers that they are within the ministries. And this is something that we still have a long way to go. I wish we had more countries like Sri Lanka, but we don't. And that's where, yes, we have seen economic growth, but that has not been translated in every country in institutional development. And that's one of the things.
Susie?
Well, I see myself as a strategic advocate. So that's really, really difficult sometimes. And as you say, there's so many different types of people that you need to change. So you're gradually changing to move towards something. So especially if you're working on reforms, you have to really understand whom you need to change and whom you need to sort of put to, one to another, things like that, not against. But, I mean, it is very tough. You have to take different pathways to do it. And it's a constant thing that you have to be advocating for different things in the health system. Yeah.
Thank you, Henry.
Thank you. I'll focus on the question on GPI transition and the end of the polio program, with the world being closer than ever to really eradicating polio. There's a high likelihood that polio-specific funding will dry up. And I think this is very relevant for two reasons. One, being that de facto the polio funding has cross-subsidized many other health programs and has cross-subsidized in a way the entire WHO and its country and sub-regional presence in many places, and these resources funded by polio did not always need to work on polio issues because you needed them as a standby capacity, so that will impact. And I think it's luckily the discussion has picked up on what to do. We'll have a big discussion at WHO on transition planning, and the organization is really approaching this quite actively, but it's a challenge. And the challenge also comes from a governance aspect, because the polio program in a way is a child of the 80s in its design. You have 5 agencies, which are the Polio Oversight Board, and they set the strategies. And the countries which benefited from these resources were not really involved in the decision making. So there was never this feedback loop which you naturally have in Global Fund and Gavi, where all countries sit on, or all country categories are represented on the board, and you decide on transition strategies. This has not been the case, and this is popping up now in WHO, of course, and might in UNICEF. That's really a challenge, and it's also something close to keeping me up at night.
Thank you. And now let's hear if Tim ever sleeps.
Thanks. Yeah, it's difficult, but I can tell you what puts me to sleep at night, and I just pick up a World Bank report, and if that doesn't work, I read my thesis. Guaranteed to put me to sleep. Just in terms of working with other sectors, I think this is the future. I was at a session on mental health this morning, and where there's just a massive set of opportunities, I think, to work with schools, with workplace, with long-term care, to mobilize resources. But 2 discrete areas that are good examples, TB and mining in Southern Africa, where rates of TB in the mines are way, way above the WHO emergency threshold. And what we've done, working with the regional Southern African development community, is created an opportunity for continuity of care across borders for the migrant health workers, and then linking this to lifelong benefits, working with unions and things like this. So it's a really nice example of public-private trans-border collaboration which is aimed at addressing a problem which to date has not been effectively addressed, and it wasn't because there wasn't any money, right? So this is really a governance challenge, and it has multiple fronts, intersectoral and transnational, but is one where I think there's some promise. On the AMR front, trying to get the animal protein production industry globally to move with where I think the market demand is for antibiotic-free produce, and looking at ways in doing that which is environmentally sensitive, which is good for agro-industry and good for health, I think is a very exciting way of moving forward in the future. The informal sector is absolutely critical, and Joe has done a lot of work, Joe Cutson at WHO, looking at the informal sector. How do you enfranchise them when tax systems are slow to develop and formal employment is slow to develop? And there is a really fascinating experiment going on in Kenya now with something called a health wallet, and it's linked to the mobile banking platform called M-Pesa. And basically what it does is it provides the opportunity of, one, contributions, but two, deductions from accounts which are not actively managed by the individual. The big problem we have with voluntary contributions is sustaining them. You'll do it once, but if you're not sick, you won't do it again. But if somebody takes money out of your account, and it's a small amount every month, you don't notice, and so you're much less likely to opt out. And so I think those are some of the solutions that might be particularly interesting. On transition financing, we, with the Global Health Leaders meeting, we agreed and provoked by somebody in Kenya who said we've got to get the 3 Gs aligned: Global Fund, Gavi, and Global Financing Facility of the World Bank Group. When we have a common discourse, then we can engage with government in one voice. And we're still not there, but I think we're moving very much in the right direction. Finally, on the World Bank, whether or not we should have a standalone health classification, I don't think it'll ever happen, just because then every sector will ask for the same thing. But I do want to point to something called the CPIA, which is developed for every country, which gives a very much more granular sense of the level of capacity. And the bank, in terms of deciding IDA eligibility and IBRD eligibility, uses the CPIA. We do not use the classification on low-income country, middle-income country. We produce that as part of producing statistics, and we don't recommend that other institutions use it. But we produce it because it's good information in terms of how we're doing overall for development. So I just want to make that clear on our various classification systems for countries.
So thank you very much to the panel. I'm aware 1 or 2 questions were not answered by the panel. Maybe you can still grab someone up here. Your much deeper question, are we tinkering on the edges? Your question about education, etc. So maybe there's still some chance for dialogue. Maybe some of you want to go next door. There's a discussion on access to medicines. I'd like you to say thank you to this fantastic panel. I've learned a lot. Thank you very much from my side. Thanks a million.